Alright guys, as promised, I was going to redo the facial bones lecture. It was all out of sorts and such, so I've done a revision of it. Hopefully this one's a little bit better. Alright, so starting out with an anatomy lesson, like we always do in procedures class, we're going to do the anatomy of the facial bones. There are 14 facial bones. A lot of them are paired, as you can see here on the right hand side of the slide. Left and right nasal, left and right lacrimal, maxillary, zygomatic, palatine, and then inferior nasal concha there in the yellow in the picture. And then the unpaired bones are the vomer and the mandible. Okay, this is just a side view. Notably on the side view, we get a better look at the maxilla and the anterior nasal spine, which the tip of which is called the acanthion, which we were already familiar with. Important vocabulary here is the alveolar process, which is the spongy bone that acts like sockets for the teeth, both on the inferior maxilla bones and the superior aspect of the mandible. Okay. So going into the maxilla or the maxillary bones, there's a left and right maxillary bone. It is the largest immovable bone of the face. It articulates with all the other facial bones except for the mandible. It doesn't have a direct articulation with the mandible. It also articulates with the frontal bone and the ethmoid bones. Okay. The ethmoid bones making up most of the interior of the nose. Okay. The maxillary bone plays an important, it houses the maxillary sinus, but it plays an important role in the shape of the orbit. It forms like the medial floor of the orbit. All right, and again, mentioned the alveolar process. That's the spongy bone that supports the roots of the teeth. And then we mentioned the anterior nasal spine, the tip of which is called the acanthion, you're already familiar with. All right, our nasal bones sit on the bridge of the nose, okay, and they are paired. There's a left and right nasal bone. Nasal bones are commonly fractured. Okay, Friday night calisthenics. Okay. So for the articulations of the nasal bones, they articulate with each other along the mid-sagittal plane, very much like the parietal bones do. Superiorly, they junction with the frontal bones. Right at the nasion is the nasal frontal suture. Posterior superiorly with the perpendicular plate of the ethmoid bone, which is in the dark green there. You can see it inside the nasal cavity. And then laterally on each side with the maxillary bones, left and right maxillary bones. Kind of got just that little protuberance in there sticking in between the nasal bones and the lacrimal bones. All right, our zygomatic bones, or the zygoma, is the cheekbone. Okay, it's roughly shaped like a three-legged stool. So it forms the lateral and inferior quadrant of the eye socket. Okay. It has a prominence on its inferior aspect. Okay. That is the, when you say my cheekbone, and you mash on that you're mashing on that edge of the zygoma and the junction of it with the maxillary bone. The maxillary zygoma junction is the location of the orbital blowout fracture. You can't really see it on this one, but you can see it on the frontal picture of the facial bones, or the frontal illustration of the facial bones. It's one of the ones, we have a special radiograph for that. It's called the modified Waters projection that we'll be talking about later in the lecture. Okay, and of course our zygomatic arch, the temporal bone has a zygomatic process that it extends anteriorly to junction with the temporal process of the zygoma, which forms the zygomatic arch, which is right there in the white, right past the letter A in zygoma on the illustration. Okay, and we have a radiographic series for the zygomatic arch, because that is one of the other places nasal bones commonly get fractured and zygomatic arches commonly get fractured. And then mandibles commonly get fractured. Okay. The palatine bones, you only see the palatine bones on one illustration, and that's the bones of the orbit. Palatine bones are largely hidden from view. Otherwise, they're in the middle of the face, left and right on either side of the ethmoid bone. Between the maxillary bone and the sphenoid bone is where you'll find palatine bones, so slightly below and behind the ethmoid bones. Okay. The palatine bones are L-shaped. They have a horizontal plate and a vertical plate. So the horizontal plate articulates with the maxilla, and it forms the bony palate, the roof of the mouth. The vertical plate extends upward between the maxilla and the Turgorite's process of the sphenoid, okay, in the posterior nasal cavity. So it forms the walls, the lateral walls of the posterior nasal cavity. The vomer forms a lot of the floor and the inferior nasal septum. So the floor of the nasal cavity and then also inferior nasal septum. Superior border articulates with the body of the sphenoid bone. Anterior border articulates with the perpendicular plate of the ethmoid bone. Okay, so it's farther back than it looks in the diagram. Okay, and its posterior border is free. It doesn't articulate with anything in the posterior border. Just kind of comes to an end, okay, opening up to the nasopharynx. Okay, and then here are the bony structures of the eye. And so this is a diagram I do feature on upcoming quizzes, so you should look at this diagram very carefully. The frontal bone forms basically the entire superior orbit. The lateral and inferior lateral corner is formed by the zygoma. And then the medial corner inferiorly is formed by the maxillary bone. Okay, and then in the back of the orbit, behind the eyeball, the ethmoid bone, the palatine bone, and the sphenoid bone form the back wall of the orbit. And of course, there's foramen back there allow for passage of the optic nerve. And then the lacrimal bone sits on just inside the medial rim. The lacrimal bone houses the duct of the same name, which is the tear duct. So that's where the lacrimal bone gets its name. All right, and then finally our mandible. The mandible, probably the most familiar to you of all the facial bones, because we talked about it so extensively when we covered the cervical spine. Okay, the mandible is the largest, densest bone of the face. Its body is the horizontal portion. The rami is the vertical portion. The angle of the mandible is the junction of the body and the ramus. It's called the gonion. Okay. The mental protuberance is anterior. It's a triangular prominence anteriorly at the bottom of the mandible, most anterior, and it's where the two sides of the mandible meet at the symphysis of the mandible. The two bodies meet, left and right. Okay, and we see an anterior view and a lateral view here, pictured on our slides. Okay. So the symphysis, the most inferior point on the symphysis is called the mental point. Most anterior and central part, where the left and right halves fuse. The alveolar process, similar to the maxillary bone, it's a spongy bone, this time superiorly on the body of the mandible to house the roots of the teeth, provided those are optional in Tennessee, so maybe housing the roots of the teeth. Excuse me. And then the mental foramina, kind of at a 45-degree oblique to the mental point, is a small opening on the body of the mandible that transmits nerves and blood vessels to the front of the jaw, the soft tissue in front of the jawbone. Okay. The mandible on the rami has a condylar process, a coronoid process, and a mandibular notch, kind of a sweeping arc in between the two. The coronoid process includes the neck and, or I'm sorry, not the coronoid, the condylar process includes the neck and the actual condyle of the mandible, and that articulates with the mandibular process of the temporal bone to form our TMJ joint, which we have special x-rays for those joints as well. All right, getting into our projections here. And I think this slide is in order, so I'm going to talk about general patient considerations in the next slide, but lateral facial bones, we can do this seated, standing, or upright, and it's very much same positioning as lateral skull. You're going to find that the listening in at the door technique works very well. Oblique the torso 45 degrees toward the image receptor, and then turn the mid-sagittal plane of their head to be parallel with the image receptor. Okay, interpupillary line perpendicular to the IR, so no tipping of the head left to right. And as far as raising the chin goes, the infraorbital meatal line should be perpendicular to the front edge of the IR. So if they're in a standing or a seated position, the IOML is horizontal in that situation. That's what that means. Okay. General considerations for setting up for facial bone x-rays, same as for the skull. Glasses, earrings, necklaces, piercings. I forgot to add piercings there. You should request to remove those. Those artifacts are going to adversely affect the quality of the images you take. Earrings more in a lateral, and then glasses and necklaces more in our APs and our AP axials. And again, preferred positioning easier on the patient if the patient can tolerate standing or sitting at the vertical image receptor. Okay, so this is what our picture, this is what our picture would look like if they didn't mess up the centering on this picture. So I already mentioned that last week. You're actually supposed to center halfway between the outer canthus of the eye and the EAM. So that would imply about halfway down the orbital meatal line, with the infraorbital meatal line running horizontal. So this center is, this centering point that they've shown you is about ½ inch too far anterior and about 1 inch inferior of where it needs to be. So just be mindful of that. They didn't, I don't know why they did it this way, but this is wrong centering, and it doesn't agree with what they say in the written instructions for centering. Okay. This is, however, what the radiograph should look like. So you should see all. So what is proper collimation? Well, you want to go, the facial bones end at the TMJ, so you want to make sure you have the EAM in the light field. If you go beyond the EAM posteriorly with the collimation light, then you have all the facial bones anterior to that. Okay, anteriorly, you got to open up to the soft tissue of the nasal cartilage. Superior to inferiorly, usually opening up inferiorly to include the mental point and all the soft tissue of the mandible, and then that will be enough coverage of all the pertinent anatomy. Okay, the frontal sinus is the end of the technical end, and well, the roof of the orbits is the technical end of the facial bones. So, but opening up to include the tip of the jaw usually opens up well past the frontal sinus. All right. So how do we know if it's not rotated? Well, the maxillary sinuses are going to be superimposed. The TMJ joints are going to be superimposed. The gonions close, but not quite, as we can see in the diagram. Alveolar surfaces should be superimposed. So just structures that repeat themselves left to right. Orbits should be superimposed. Sella turcica should be open in profile, and you should see the sella turcica on. You should open, because you're opening beyond the EAMs. So you should see the sella turcica in profile, and that gap open between the anterior clinoids and the posterior clinoids of the sella turcica. Right, so yes, just one more time, what are we using this for? All the sinuses are revealed, and of course when we learned sinuses last week, we knew that the lateral projection is one of the projections that demonstrates all the sinuses. So we're going to see the magnitude, that is the volume of the sinuses, superiorly and inferior dimensions of the sinuses. Now, the maxillaries and the frontal sinuses are going to be superimposed with each other, left to right. Thickness of the frontal bone can be evaluated. Detail side closer to the image receptor. So what that means is you're not always doing a left lateral. You need to evaluate patient history. If they have contusions on the right side of their face, you need to do a right lateral rather than a left lateral. If they have contusions all over their face, you might consider doing both laterals. Okay. So the facial bones of the side closest to the image receptor are going to show up in better detail. All right, moving on to our next projection. It is the Waters projection. Keep your head above water. And so with the Waters projection, like we explained last week, the Waters projection is great for maxillary sinuses. So I kind of walked through it last week with a verbal description. The OML forms a 37-degree angle with the plane of the image receptor. The mental-meatal line is perpendicular to our image receptor, but we're not centering to the mental-meatal line. That's very important. The central ray exits the level of the acanthion for the Waters projection. Okay, so hyperextension of the head and the neck until the MML is running horizontal in a vertical setting, but then direct your central ray to exit the acanthion, and of course you're in detent. And typically 8x10 or 10x12 field is sufficient for a Waters projection. Portrait orientation. Okay, and this is what our Waters projection will look like. The frontal sinuses and ethmoid sinuses are foreshortened because we're tipping the head so far back. So there is some distortion. The maxillary sinuses present the best. And you can tell you've positioned correctly. That is, tip the chin back far enough because the petrous ridges are projected immediately below the maxillary sinus. The whole point of the Waters projection is to ideally demonstrate those maxillary sinuses and the maxillary bones. Those have the lowest OID, and the petrous ridges are out of the way. Okay? We do get a very good evaluation of the entire orbital border with a Waters projection as well. Okay? We get a good evaluation of the zygoma bone with a Waters projection, and the perpendicular plate of the ethmoid bone, which we can see this poor fool has it deviated for some reason. Okay. Collimated border, you need to open, if you're doing sinuses, open to the edge of the sinuses so you can collimate a little bit closer to the center of the face. But if you're doing for facial bones, you need to open to the lateral borders of the skull. And the orbits need to be symmetric relative to the lateral borders of the skull. So if you go to the lateral border of the orbit and then measure the distance to, you can just, kind of measure it with your fingers on the screen if you want to, or you can use the measurement tool. And then just measure that distance. It should be about 1.5 to 2 centimeters, depending upon if they're meso or brachycephalic. But it should be symmetric to the other side. So one of the orbits should not be closer to the lateral aspect of the skull than the other orbit. They should be the same distance, okay? Or appearing symmetric on the radiograph. All right. And so that's a quick sign for rotation, and that's a sign for rotation for basically all the APs and PAs is symmetry of the orbits if the orbits show up. The Townes projection, it's symmetry of the petrous ridges. So, all right, so in a trauma situation, when you're not able to stand your patient up, this is the only time I would recommend doing a reverse Waters. A reverse Waters is a poor substitute for a conventional Waters. So if your patient can tolerate a conventional Waters, I would do the conventional Waters projection. It's a better projection. This will give us the same look at the anatomy, but remember we've got increased OID now, So all that anatomy, the same anatomy that I said well demonstrates on the regular waters, will now be magnified and slightly blurry, but you'll still see it. So in a trauma situation, this is preferable. Now, good luck hyperextending the patient's chin. In a trauma situation, what you would probably rather do is spot the mental meatal line, line up your central ray to the mental meatal line, running parallel to the mental meatal line, and then shift the position of the centering to enter the acanthion, and then line up your table bucky to the central ray. Or you could have bucky tracking, and so as soon as you move the centering of the tube, the bucky tracks to it. So, or with a floating tabletop, just move the patient. But yeah, as far as the direction of your central ray, it should be running parallel with the mental meatal line. Okay. So what I'm telling you is you might not get your patient to tip their chin back like this in a trauma situation, right? I would not substitute this on a regular basis, only when the patient's not capable of doing the conventional waters. Again, the angle of the OML to the image receptor is still a 37-degree angle. Okay. So our reverse waters, again, looking very similar, but you can see that the edges of the orbits, the edges of the maxillary sinuses, all the fine detail structures that we're trying to see, everything's just a little bit blurry and just a little bit bigger, just a little bit magnified. We should see the Peters ridges still below the level of the maxillary sinuses, and we should see that the lateral border of the orbits left to the lateral border of the skull, that distance should be the same as the lateral border of the right orbit to the lateral border of the skull on the right side. So symmetric orbits, basically. Okay, that's your sign of rotation. If the orbits are asymmetric, one of them is closer to the edge than the other one, then the patient is turned in that direction. Okay. Modified waters, I did tell you that there was a orbital blowout fracture that's possible. So your eyeball sits on a fat pad, like a fatty pillow, okay? And then that fatty pillow rests on the bony orbital floor. And it kind of just cushions, your eyeball is surrounded by fat pads to cushion the eyeball so that if you take a hit to the head, your eyeball doesn't immediately just burst and rupture. It's got built-in shock absorption, 360 degrees surrounding it. So, but if you do fracture the bottom of your orbit in what's called an orbital blowout fracture, where the zygoma separates from the maxilla along the suture line, the fat pad, the inferior fat pad, can start to leak down through that fracture. And the fat pad, it's kind of gelatinous. It's not really a true liquid, but it's not really solid either. And so we say it drips down, but it doesn't get all the way down through. It kind of hangs in the middle of the maxillary sinus, and it forms a teardrop sign. Okay, so the teardrop sign is an indicator that an orbital blowout fracture has occurred. It's a hanging fat pad in the middle of the maxillary sinus, usually diagnosed on CT nowadays, but the modified waters shows it off beautifully. What the modified waters does is it makes it so the orbital floor is perpendicular to the image receptor. Okay, so we lessen the tilt of their head. You know, for the waters projection, we crank their head back really a whole lot. It is true hyperextension of the head and the neck. This time we have them tuck their chin slightly. They're still got an elevated chin, but it's not as aggressive. And so now we want to make the acanthomeatal line running perpendicular or horizontal in a vertical bucky projection. Acanthomeatal line, central ray still exits the acanthion. Acanthomeatal line horizontal, OML now a 55-degree angle with the image receptor and the orbital floors. The notable thing about the modified waters is the Peters pyramids will come up a little bit creep into the bottom half of the maxillary sinus, but the orbital floors will be a true perpendicular to the image receptor. So we'll be able to see right along the plane of the orbital floors. And I think I have those. Yeah, here they are. So here's the position. See, we've tipped their head less aggressively than before. And we get a beautiful X-ray of the orbital floor. Right there, it's just a single line, completely perpendicular to the image receptor. And so that's the area of interest. And we can see that the Peters ridges have come up to about halfway up the maxillary sinuses. So, yeah, you do the modified waters if and only if there's a suspicion of an orbital blowout fracture. Okay. All right, so what does our waters method show us? Well, similar to what we learned, it shows it's the best representation of the maxillary sinuses. You do see the frontal and ethmoid sinuses, but they are foreshortened vertically. They're distorted. Superiorly to inferiorly, they appear shorter than they actually are on the waters because we're tipping the head so far back. And again, the whole point of all these positions, AP to PA and all the axles that we do and everything, is we have to get the Peters pyramids the heck out of the way of what we're trying to see. And for the waters, we're trying to get them the heck out of the way of the maxillary sinuses. So not the modified waters, the waters. For the modified waters, we're trying to get them the heck out of the way of the orbital floor and present the orbital floor in a true perpendicular. So, all right, moving on. So that was basically our facial bone series. You will do an SMV, but I already taught you how to do an SMV the last time. I'm going to repeat the SMV coming up for the zygomatic arches anyway. So we'll see that a little bit later. So you would do like if you're doing a facial bone series, you do like a lateral facial bones, a waters, a Caldwell, and an SMV most likely. Okay. So for our nasal bone series, we're going to do a waters or modified waters because we can evaluate deviation of the nasal bones left to right on the waters projection very well. And then we do but we typically do bilateral. Right lateral nasal bones and left lateral nasal bones. Okay? And so we start with a lateral nasal bones projection, mid-sagittal plane parallel with the IR, IOML parallel with the long axis of the IR. So this is laying down, but and that's probably the easiest way to do that is laying down, especially with the big digital image receptors that we're using now. You want to do this tabletop with a pinky finger technique. So like 50 at 1.6 is perfect for nasal bones, or 50 at 1.2. You're directing your central ray to the nasion or the nasal frontal suture. Okay. The patient suspends respiration and you do both sides for comparison. So open your collimation to the outer canthus posteriorly, and inferiorly open it to include the acanthion, because if they fracture the nasal bones, they might have a contusion to the acanthion and the anterior nasal spine as well of the maxillary bone. All right, so there's our proper collimation. Back in the day, we used to lay down lead rubber on a 10x12 cassette and shoot 2 exposures on 1 image receptor cassette. We can't do that in the digital age anymore. Just collimate down to, it's roughly the size of the ion chamber in AEC. It's roughly a 2x4 square, or 2x4 rectangle rather. But open up anteriorly to include the nasal cartilage, open up posteriorly to include the outer canthus of the eye, open up superiorly to include the frontal nasal suture, and inferiorly to include the acanthion, right? And that's a proper lateral nasal bone. And since you're shooting both the left and the right, make sure you mark those appropriately so the radiologist can tell which side is closest to the image receptor. Okay. Moving on into our zygomatic arch series, this is where I'll cover the SMV for facial bones. It just shifts the center basically versus the SMV for skull. We move up or anteriorly just a little bit with our SMV. So let's get into that. The SMV series starts with a modified Townes. So a conventional Townes, we're going to make the OML perpendicular, mid-sagittal plane perpendicular, and we're going to invoke a 30-degree caudal angle. For a conventional Townes, we center 2 inches superior to the glabella. For the modified Townes for zygomatic arch, we want the central ray coming right through the level of the zygomatic arch. So we're centering right at the glabella, or 1 inch superior to the nasion. Okay. Ignore that part about the forehead and nose resting on the IR. That's for a PA. That's not for an AP. So, okay. The modified Towne for zygomatic arch, it's an ugly little radiograph. You need to open the collimation posteriorly to include the EAMs, open the collimation anteriorly to include the cheekbone, and I would say the acanthion, okay, because the zygomatic arch ends at the cheekbone. So if you have light on the acanthion, you definitely have collimated light on the cheekbone. If you have light on the EAM, you have light on the posterior part of the zygomatic arch, the zygomatic process of the temporal bone. Okay, there is superimposition of the zygomatic arch with the rami of the mandible. That can't be helped, but the zygomatic arch do bow out laterally quite a bit from the rami of the mandible. They should be bowing out symmetrically beyond the rami of the mandible. So if the mandible is superimposing on one side and not on the other, then your patient's mid-sagittal plane is not perpendicular. The patient's head is rotated. Okay, so symmetric presentation of the zygomatic arches. The submento vertex for zygomatic arches, the zygomatic arches show up really well on the SMV projection. And so we're not interested in the sphenoid bone as much like we did for the skull. So we're cheating forward from the gonion to the 1 inch posterior to the outer canthus of the eye, which runs right in the middle of the zygomatic. It's basically the midpoint of the zygomatic arch. Okay, and you can see that the light, the targeting light shadow for the horizontal targeting light, that's intersecting her jaw right there, and then if you trace that line superiorly, it cuts right through the middle of her zygomatic arch. Now, the tube angle, remember, for the SMV, we want the IOML to be vertical if the patient can do that. If they're not capable of that, we're going to have to compensate with a cephalid tube angle to make sure at least our central ray is coming in perpendicular to the IOML for best demonstration of those zygomatic arches. So open the light field, extend the light field about a ½ inch beyond the EAMs, and then extend the light field anteriorly to the acanthion and the soft tissue of the nasal cartilage. Okay. And this is our submento vertex zygomatic arches. The image looks dark because it's screen film. You would see more soft tissue landmarks on a digital image receptor. Okay, more soft tissue detail. So there's our zygomatic arch, and again, similar to the modified Townes that we just went over, they should appear symmetric to the bones of the mandible, and you can see on the inside there the body of the mandible, and so it goes zygomatic arch, then lateral skull, so temporal bone and frontal bone right there, temporal frontal bone boundary, and then body and ramus of the mandible, okay, at the middle. So all three of those should be symmetric. The distance between the zygomatic arch and the border of the skull should be symmetric, and the distance between the rami of the mandible and the border of the skull should be symmetric. If those are crowded and bunched up on each other without good gaps between them on one side and more spread out on the other, then the patient's head is rotated and the mid-sagittal plane is not perpendicular to the IR. Okay? For our tangential zygomatic arch, probably in this lesson the most difficult position to obtain, we're going to start out with an SMV and then we're going to rotate the mid-sagittal plane 15 degrees toward the side we want to see. Okay, hang on just a second. All right, so after turning the head toward the side we want to see, that'll make the zygomatic arch bow out just a little bit. And then we have to tip the head away from the side we want to see. So turn the head, so if we're trying to do the right zygomatic arch, you turn the head 15 degrees toward the right, but then tip the head back 15 degrees away. So tip the left, so toward the left parietal bone, basically. What that does is it makes the zygomatic arch be the most superior aspect of the person's head right there. And then we direct the central ray right to that zygomatic arch. So we're isolating the right zygomatic arch in this picture. You would, of course, have to do a separate projection for the left zygomatic arch. And so they often call this the modified SMV for zygomatic arch. And because it just basically, the way that the zygomatic arches bow out on the SMV, we're exaggerating that bowing with manipulating the head in these two directions like this. So rotate toward and then tip away. Both of those 15 degrees. Okay. And you just get a very nice tangential view of the zygomatic arch. And it's supposed to look like that radiograph there. Yes, the collimation is only half the head, so you can literally stop the collimation at the mid-sagittal plane. The central ray enters 1 inch posterior to the outer canthus on the side being imaged. So you're not centering to the mid-sagittal plane anymore. Okay? You're centering to the side that you're trying to isolate. The other side will not show up if you open the collimation to the other side. All right, moving on to individual pictures of the jaw. Now I did show you how to run the Panorex machine in lab last week. And for future classes, I'll show you how to run the Panorex machine. But before they invented the Panorex machine, we had to do like a 5-view series of the mandible. So starts out with a straight PA, so very much like the Caldwell position or the PA position, the OML perpendicular, mid-sagittal plane perpendicular. Instead of the central ray directed to exit the nasion, though, the central ray is directed to exit the acanthion. So just move the centering inferiorly from the nasion to the acanthion, and everything else is the same. The nasion basically sits in the middle, is the midpoint between the condyles of the mandible, the TMJ joints, and the mental point of the mandible. Open the collimation superiorly to be about a ½ inch to an inch beyond the TMJ joints, and then open the collimation inferiorly to include the mental point. Okay, and that PA mandible will look like this. They say this for mandibular rami, but I really think that the symphysis shows up the best on this one. Yes, it's superimposed by the C-spine. You can't really help that. But the rami and the body, remember, are heading back toward the X-ray tube in this projection. So you're not really getting a good look at those. You can see the rami, most of the rami. The condyle and the coronoid are slightly superimposed with each other on this view. The body shows up okay, but not great. The symphysis shows up fantastic, just superimposed by typically C3, C4 is superimposing the body of the mandible on this. Okay. Petrus pyramids should be filling the orbits, or so they should be just above, might be right overlapping the TMJ joints. So I can't really see the TMJ joints well on the straight PA. So if we do a modified Haas, this features a 20 to 25 degree cephalid angle, exiting again at the acanthion. So remember, the Haas exited about 1.5 inches superior to the glabella. We want to drop that down to the level of the acanthion. What this is going to do is going to elongate the rami, stretch those out a little bit, drop the coronoid processes slightly below the mandibular condyles, so we get a better look at the superior structures of the rami than we did on the straight AP. Okay, and you'll find that the mandible is slightly elongated here. Yeah, better look at the rami here with a modified Haas projection. You can see a little bit more of the gonian area of the mandible with this. Looks like they did clip very as close as you get to clipping the mental point without clipping it on this one. So as far as opening your collimation, again, you want the TMJ joint, so open up your collimation to 1/2 inch to 1 inch beyond superiorly beyond the TMJ joints. Obviously, laterally, you want to open to the borders of the skull, and inferiorly to include the mental point. Okay. TMJ joints visualized a little bit better. They are superimposed by mastoid air cells this time. So the mastoid tips and the TMJ joints will be superimposed, but you see them better than you do on the straight PA. Yeah, so the best shots of the mandible, if it's not the Panorex, are these axiolateral and axiolateral oblique projections. So it is 3 different projections, and the position change, you change the obliquity of whether the mid-sagittal plane is in a true lateral that is parallel to the image receptor, which is the upper left picture, at a 30-degree angle to the image receptor, which is the upper right picture, or at a 45-degree angle to the image receptor, which is the bottom picture. Okay, all of them a 25-degree angle to separate the side of the mandible closest to the image receptor versus the side of the mandible away from the image receptor. That 25-degree up angle shifts the away side superiorly so we can see the side closest to the image receptor, and you'll see that on the radiographs on the next slide. As far as the tip and tilt of the head or extension of the chin, you want the edge of the jaw, that is the inferior border of the body, to be running horizontal here. Okay, mid-sagittal plane variable depending upon what part of the mandible you want to see the best. Okay, and so if you want to see the rami in a true lateral, then position them with the mid-sagittal plane in a true lateral, and then center to the ramus, midway between the gonian and the TMJ joint. Okay. If you want to see the body in a true lateral, then you rotate the patient's head 30 degrees toward the image receptor so that the body of the mandible is laying flat against the image receptor surface, and then center halfway between the gonian and the mental point. Okay. If you want to see the symphysis of the mandible, you need to rotate the mid-sagittal plane in a true 45-degree oblique to the image receptor, so the whole head turned 45 degrees into the image receptor, right? And then center to the mental point from the underside. All right, so every one of these, the tube angle is the same, 25-degree cephalid, but you change the rotation of the mid-sagittal plane and the centering point center to the part of the mandible that you're trying to visualize on the radiograph. The most common one in the series is just to visualize the body of the mandible on these axiolateral obliques. So you do the 30-degree angle one most commonly if you're doing the mandible series. Okay. Unless you specifically see a fracture at the symphysis or at the ramus, you should probably just routinely, you should just do the bodies, and you will do a left one and a right one because you can't see the right side body on the left axiolateral oblique, and you can't see the left side body on the right axiolateral oblique. All right, so moving on to our TMJs, and then I think we get to orbits to wrap this up. For our TMJs, we're going to do a very steep, it's kind of a Townes again, but we're increasing the tube angle for this. So it's just called AP axial TMJs. And then we do a axial lateral oblique similar to the mandible, but for the TMJ joints. So we're actually going to angle caudate instead of cephalid for the axial lateral oblique of the TMJs. Okay. So if you're doing a TMJ study, you're going to do both of these projections, left and right. The AP axial TMJs are bilateral. So you get left and right in one radiograph, but you do them open mouth and closed mouth. Okay, so you're going to do 2 projections. Each time when you do the axial lateral obliques, you're going to do a left side down and a right side down, open mouth. So that's 4 open mouth and closed mouth. Left, open mouth, and closed mouth right. So 4 projections there, and then 2 projections of the very steep modified Townes for TMJ. Okay. So upright or seated, typically seated because of the limits of your crane, your tube crane. Laying down if they just can't stand up. Mid-sagittal plane perpendicular to the IR. OML perpendicular to the IR, so they tuck their chin quite a bit, right, like they do in the Townes projection. Okay, and then we're increasing the tube angle to 35 degrees, and then the central ray enters or passes through the TMJ joints. So it doesn't really give you like an anterior landmark. I would put that at probably about an inch superior to the glabella. Oh, they say 3 inches superior to the nasion. Okay. So the targeting light, as it sweeps around, the black stripe should pass through the TMJ joints, which remember are a ½ inch anterior to the EAMs on your patients. Okay. Open the collimation to I would go about 1.5 to 2 inches superior to the TMJs, and then 1.5 to 2 inches. So down to the acanthion, and then about 1.5 inches superior to the EAM. Okay. Side to side, open to the lateral borders of the face, obviously. One with mouth open, one with mouth closed. Okay, because largely the TMJ joint, as far as evaluating for pathology, is arthritic and inflammatory change, and they need to see it open and closed, the joint open and closed. So this is a representative radiograph with the mouth closed, I believe. And there you can see the condyle of the mandible and the ramus of the mandible on the TMJ joint. So we don't need the entire mandible. We can clip mandible. We just need the TMJ joint midway between top and bottom of the image receptor. And you can see with the rest of the structures, it does look very much like a Townes or a Haas, because you can see the sphenoid, the foramen magnum, and I think the dorsum sella all right on top of each other, right in the middle. So you want to see open TMJ joints if you can. The mastoid processes are going to be slightly superimposing. Petrus pyramid should be elevated and way out of the way. It should be at the very top of the radiograph, pointing toward the foramen magnum, like we see in a Townes and a Haas projection. Okay. You should see the coronoid of the ramus free of the condyle. So the coronoid should be below the condyle. So you should see the condyle and the neck of the ramus mostly free of superimposition of other parts. Okay. And again, open and closed. So 2 exposures here, 2 different exposures. One with mouth open, one with mouth closed. Okay. Same thing for the axiolateral TMJs. You're going to do one with mouth open, one with mouth closed. For this one, we want the IOML to be running horizontal. Okay? Mid-sagittal plane parallel to our image receptor. God bless, excuse me. Okay. And then the image receptor centered to the TMJ of the side closest to the image receptor. So for this one, she is demonstrating her left TMJ. So we just put the TMJ right there on the crosshairs of the image receptor, invoke a 30-degree down angle on our X-ray tube. And what that does is it projects that downside TMJ basically right over the pterion, which is the junction of the frontal and squamosal sutures, right in that area, like in the high temple area, okay? Right at the very top of what you would consider your temple is where that TMJ joint is going to display. And it's just all flat bone right there. There should be no structures. The sella turcica is probably going to be the closest structure inferiorly, but it should be about an inch above the sella turcica when the picture shows up. The away side TMJ does sometimes show up, but it is magnified and blurry. So we might see that, and I think they show that on the representative radiograph. Yeah, with a black arrow, you can see the away side TMJ joint. And then the elevated side TMJ joint didn't quite get separation with the sphenoid bone and the orbital roof there. So just peeking above the orbital roof there in the dotted lines. Okay, so that's what those radiographs look like. And now you can see why we do CTs on these things. So, okay. Centered to a point ½ inch anterior to the EAM, or in other words, centered to the TMJ joint of the side closest to the image receptor. Okay, mid-sagittal plane is parallel, so you don't have to rotate them. Okay, in a pupillary line, perpendicular. Oh, they say acanthial medial line. I was taking a guess there. Transverse axis. So the acanthial medial line is horizontal, not the infraorbital medial line, like I just said in the previous slide. God bless. Now you have to cross through that on your notes. I'm sorry. Okay. All right. For our orbit series, VA Nashville still does the Reese obliques. The Reese obliques have not been in the Merrill's Atlas for almost 7 years now, so big fun. So I have record of the Reese obliques. I remember how to do the Reese obliques, and I have them in this PowerPoint. So one of the few places you can still learn how to do the Reese obliques is in my PowerPoint. So we'll do a Caldwell. You know how to do a Caldwell. We'll do Waters or modified Waters. Probably for orbits, the modified Waters is better because we get that view of the orbital blowout fracture. The modified Waters is specifically designed to evaluate for the orbital blowout fracture. Lateral facial bones, of course, because we see the entire orbital cavity in profile on our lateral facial bones. And then the Reese oblique, which is what's on the next few slides. So I've already gone over all those other positions elsewhere. So let's jump into these Reese methods. You will do a left and right in pairs. So very much like the zygomatic arches, you can only see one of them at a time. Okay. Now the other orbit, you can see it kind of like you can see the orbital rim in profile. So maybe open the collimation to include the away side orbit in profile, maybe not. The acanthial medial line runs horizontal, perpendicular to your image receptor. Okay. The only critique I have of this demonstration is the Bucky is too low. We need to center to the downside orbit, so raise this image receptor up about an inch. We're centered at the acanthion here, and that's a mistake. Okay. So direct the central ray perpendicular to the downside orbit. The mid-sagittal plane will make an angle of 53 degrees with the image receptor for the Reese method. The Reese method is also called the three-point landing. The tip of the patient's nose, the cheekbone, that is the zygoma, and the tip of their chin will all rest and make contact with the vertical image receptor. So it's a three-point landing projection is what the texts call it. Okay. As far as what questions am I going to ask, center to the downside orbit, that's a good question to ask, and what is the angle of the mid-sagittal plane for the Riesz projection? It's a 53-degree angle with the image receptor. Okay. And this is what a Riesz method would look like. Okay. You can tell you have a good Riesz method because you can see down the optic nerve or the optic foramen where the optic nerve passes through, and that's going to be in the lower outer quadrant of the orbital border. So you'll see the orbital border that is facing the image receptor is on full display. The other one is turned away, and you can partially see the lateral orbital rim in profile if the collimation is opened to that much. But you really need, you can do like a 4x4 collimation on this, and you're really only expected to see the downside orbit or the orbit of interest. So you'll do a left one, and then you'll do a right Riesz for every orbit series that you do that involves a Riesz method. All right, that's all that I have for the facial bones, guys. Sorry about the mess up with the previous PowerPoint that wasn't revised properly. This one's in a little bit better order, and I'll be repeating that lab. And of course, for future classes, I won't be repeating that lab, but for this year's class, I'll be repeating that lab on Monday. So see you guys on Monday.